Hello everyone and welcome to this evening's webinar. Thank you for joining. I'm Liz Barton, I'm Head of Communications at VET.CT, and in a moment I will introduce Olga Travetti, our speaker, more fully. But before that, while we wait for everybody to join, I'm just going to tell you a little bit about VET.CT and how our radiologist services can help you, your teams and your patients. So VET.CT is a global company with over 150 radiologists who are all here to help you. Whether you're in first opinion practice, we work with universities, specialty hospitals, all types of clinical settings. Our team of radiologists provide expert interpretations on a range of imaging modalities, including X-ray, CT, MRI, fluoroscopy, and nuclear scintigraphy for all species. And really what sets us apart, what we focus on, is the quality of our reports and our exceptional radiologists providing annotated images to highlight areas of concern. So we also ensure that the reports that you receive contain clinically relevant differentials and comments, and all of our reports are backed by our unique clinical warranty, so you can really trust the information in them and proceed with the next steps for your patient with confidence. We also have a great support team who are all clinically trained and are available 24/7, so you can ask them for help and support at any time. And you can also communicate directly with our team of radiologists if you have any questions about your case. If you could just forward the slide, please, Olga. So if you want to find out a little bit more and see what our reports look like, then please do scan the QR code on your screen and you can view some of our example reports. And you can also reach out to our client success team to find out more. So just email us to arrange a no obligation discovery call at a time that suits you. And if you could just forward that on, thank you. So just a bit of housekeeping. The webinar tonight is being recorded, and as I've said, we will share the link in the coming days via email with you, or also on our website, so you can replay any part of the webinar or share it with colleagues if you found it helpful. The talk will be approximately half an hour long, and then we will go into a Q&A session. So if you want to submit any questions, either as they come up during the talk or at the end, then please use the Q&A box in the button at the bottom of your screen. And if you could forward it on, thank you. So tonight's webinar, as I said, we're delighted to welcome Dr. Olga Travetti, who completed her residency in diagnostic imaging in Ghent, Belgium, and became an ECVDI diplomat in 2014. She has worked both in private practice and in academia, and she is a small animal teleradiology consultant at VET.CT. She's worked with us since 2018. So tonight's webinar, the use of CT in dogs and cats is rapidly growing, and we often get asked for a lot of help in improving image quality in order to improve diagnostic accuracy. And Olga's talk tonight is a discussion of clinical cases where you might want to consider CT. So enough from me. I will hand over to Olga, and I hope you enjoy the talk. Thank you, Olga.
Thank you so much, Liz. So yes, this is the fourth of a series of 4 webinars, so it's the last one, where we have covered the technical topics that were seen during the lectures that have been offered by VET.CT in the previous months, and we really try to show the key advantages of CT. We are trying really to address the common questions, such as why shall I choose CT, what information could it provide, and what shall I expect, and when is it indicated, and how can it influence patient outcome and patient care. As we said, it's a series of 4 sessions, and in each session we review 3 cases over half an hour, and at the end there is time for Q&A. These cases have been selected to show a particular aspect where we think that CT is particularly indicated or useful, and we do really enjoy interaction, so please ask any questions. So we want to show how CT is an excellent imaging modality, but also we want to show how this particular modality differs from others and what are the indications in each cases. And we want to explore how we can profoundly impact patient outcome and patient care. So without further ado, let's start with the first case, which is number 10, because we are at the end of the webinars. And this is a cat, actually, 15-year-old, quite old, with a 2 weeks history of weight loss and hyporexia. We have radiographs to start with, and we have a right, left lateral, and the ventrodorsal view. I have labeled kidney with K and the urinary bladder with UB. So we can see, indicated by the white arrows, that there are areas of reduced peritoneal serosal detail. This is in the right side of the abdomen and in the ventral abdomen, cranial to the urinary bladder. But we could also see, indicated by the yellow arrows, that there is a soft tissue attenuating mass that is on the left-hand side to the vertebral column, at the same level at the urinary bladder in the ventrodorsal view, but cranial and ventral to the bladder in the left lateral view. And finally, we can also observe that in the right lateral view, there is a poor delineated area of increased soft tissue opacity, just ventral to the colon and right kidney. However, this area is difficult to detect in the other views. So essentially, as a summary of the CT findings, we have mild peritonitis or peritoneal effusion because of the lack of serosal detail in a few areas. But we also have a suspected ventrocaudal abdominal mass. Because of the position, this could be a mass at the level of an intestinal segment. It could be also a lymphadenopathy, or less likely, it could be a free peritoneal lesion. And also we have an equivocal cranial peritoneal lesion, which could represent obviously an artifact, but it could be lymphadenopathy, particularly the jejunal lymph nodes. It could be at the level of the caudal aspect of the pancreas, or it could be a free peritoneal granuloma. So essentially, we do have quite a lot of findings, but not enough to formulate a diagnosis. And so the client in this case decided to perform a CT, and we do have a video here. So on the left-hand side, we have a soft tissue post-contrast, and on the right-hand side, I've prepared a parasagittal right MPR reconstruction. So when you start looking at the video, we can immediately see that there is an enlarged lymph node followed by another group of lymph nodes enlarged. These are the sacral and internal iliac lymph nodes. And then immediately cranial to the urinary bladder, we have a bit of peritoneal effusion ventrally. And then here we can see this large mass. So this is the one that we could see cranial to the bladder. It is clearly a small intestinal segment. And we know that because of the location and because of the content and the shape, tubular. And it's quite an important mass, quite big. However, the small intestine continues with a normal size. We can still see a bit of peritoneal effusion, and here indicated by the green arrows, there is this large mass. And because of the position of the mass, we can see it is at the center of the mesenteric root. So this represents jejunal lymph nodes, massively enlarged. We still see this lack of peritoneal detail, which represents a bit of peritoneal effusion. And this large mass, which is ventral to the liver and ventral to the stomach. And when we assess the attenuation with a ROI, region of interest, we can see that the attenuation of this area is -100. So this is an accumulation of fat ventral to the liver. So an intra-abdominal lipoma, which is an incidental finding, but CT didn't actually depict. So concluding, the summary of the CT findings are that we have a large jejunal mass, and this is most likely neoplastic. However, rarely we have non-neoplastic lesion that could have a similar appearance. And this is, for example, a feline eosinophilic sclerosing fibroplasia. However, it is less likely because of the age of the patient and the location of the disease, because this condition tends to be more pylorus or duodenum. We have a multifocal lymphadenopathy, as we saw, internal iliac, sacral, and jejunal. And we have a small amount of peritoneal effusion and an incidental intra-abdominal lipoma. So we do have a diagnosis in this case, thanks to CT, and we have clarified some of the areas that were doubtful on X-ray. We have diagnostic differential, and what we have justifies the clinical presentation in this patient. We did have the lungs as well, which I didn't show because it would have been too long, and we have identified that there are no pulmonary metastases. And we can importantly also observe from the CT that there is no secondary mechanical obstruction, because one of the frequent problems with large intestinal masses is that they cause over time a mechanical obstruction. And this is obviously posing a great clinical problems to the client, to the patient, that needs to be addressed. In this case, we could see that that was not the case because the rest of the gastrointestinal tract wasn't enlarged. Could we have achieved it with other modalities? This is what we always ask ourselves. Yes, we could have done an ultrasound. Ultrasound is excellent in small patients, so cats and small dogs. However, it requires an experienced operator, so a person that has a certain experience for interpretation and taking images. And also the other limitation of ultrasound in this case is that it doesn't matter how much we scan the abdomen and we swipe left to right and so on, we are not able to actually follow the gastrointestinal tract from the level of the pylorus to the level of the rectum. We can see as many intestinal segments as we can, but we cannot follow it thoroughly. Instead, this is what we can do with CT. Because we have three-dimensional reconstructions and because we can really take the time to follow the intestinal tract thoroughly. This can be important in cases such as, for example, a lymphoma, like what is the potential diagnosis in this case, because we want to stage the patient thoroughly, and occasionally we do have a massive lesion somewhere, but we have other smaller masses elsewhere. So being able to thoroughly follow the whole gastrointestinal tract is something that we can do easily with CT. And the same goes for very small lymph nodes that are only mildly enlarged. We can see them and we can measure them in 3 dimensions. So how did it impact the patient? The cat in this case has a likely diagnosis. We can think about the next steps, which will be sampling, because ultimately this will be necessary for a definite diagnosis. And with CT, we can guide the 5-needle aspirates to maximize the chances of a conclusive result. So the key points in this case are that CT is excellent for the gastrointestinal tract, provided that we do have post-contrast series, and is a wonderful complement to abdominal radiographs when radiographs do not give us all the answers, or radiographs raises some doubtful questions that we cannot completely answer. However, CT cannot visualize the gastrointestinal wall layers. This is something that ultrasound instead can do. And so if we have a case where we have only subtle thickening of an intestinal segment with maybe a mild altering of the layers, ultrasound may actually be preferred to CT. CT is more indicated when we have a proper intestinal mass or gastric. Ultimately, though, even when we perform ultrasound, we have to do sampling, because neither of the modality gives us a complete diagnosis. For that, we need the combination of the imaging and the cytology or histopathology. However, CT for abdominal disease, particularly gastrointestinal, is better than ultrasound for changes that are caudal to the pubic bone. So, for example, if you suspect a mass within the wall of the rectum, with ultrasound we would struggle to see it because the pubic bone would shadow that area. So as usual, I've prepared a small list of different of literature sources for this type of condition, and because the webinar is recorded, you can have a look at them if you want to later. So continuing with our case series, case 11 is a German Warhair pointer, 4 years old, neutered, with a known history of megaesophagus, stable. The dog, however, is vomiting intermittently for 2 days, and concerning, there is some blood within the vomit. So the patient arrives with radiographs, and we can see we only have one view, and unfortunately part of the caudal chest and the complete abdomen are out of the field, so we don't know what's going on. However, there are quite important and concerning changes in this case. So we have a large soft tissue opaque mass that is dorsal to the heart and is compressing the heart and the trachea ventrally. We suspect that this mass is mediastinal because of the ventral shift of the mediastinum. And we also have a tracheal stripe sign. So we can see the wall of the trachea ventrally and dorsally. We are not supposed to see the dorsal wall of the trachea because we are supposed to have gas only ventral, which is the lumen of the trachea. And also the cranial margin of the large dorsal mass is really well delineated. And we can see that actually the element that delineates the mass is free gas. So we do not see the interstitium of the lung at this level, but we see free gas. So we have free gas in the dorsal mediastinum, and we have this large mass. So we could think about a pneumomediastinum, so gas in the mediastinum, but this is not the case, because if that was the case, we would probably see the brachiocephalic trunk and the cranial vena cava ventral to the trachea, and we cannot see that. We can see that's just the lungs. So we have to suspect that this gas, more than being in the mediastinum, is within this an organ in the mediastinum, and this is within the esophagus. And then just superimpose onto the cardiac silhouette, we can see these fully delineated areas of interstitial to alveolar opacification, which are quite concerning because we have a dog with megaesophagus, so we are thinking about aspiration pneumonia as well. So summarizing the X-ray findings, we have a well-delineated dorsal thoracic mass that is most likely mediastinal, with a tracheal stripe sign indicating pneumomediastinum, or more likely esophageal gas. And we have an alveolar opacity superimposed on the cardiac silhouette indicating most likely aspiration pneumonia. So the lesion could be is most likely in the esophageal lumen, we suspect, and in that case we have two options. We have a gastroesophageal intussusception, which is a surgical emergency, or less likely an esophageal foreign body. But this is quite less likely because of the shape of the lesion and because of the size of it. The other differential, of course, would be to have a dorsal mediastinal mass with superimposed mediastinal gas, either outside or within the esophagus, because the dog has also a megaesophagus, so we don't know if the air is superimposed or not. So the client elected a CT, which in this case is an excellent choice. So I have two videos here. On the left-hand side, a soft tissue post-contrast transverse, and on the right-hand side, a pulmonary algorithm. And already from the start, before I start the video, this is the wall of the trachea, and this one here is the wall of the esophagus, which contains gas. So I'll go quite quickly, and then there is another slide showing the changes more in detail. So within the esophagus, we have this large mass with a double layer, as you can see. And within this lesion, this structure, we have a little bit of mesenteric vessels, some mesenteric fat, and this triangular contrast enhancing structure that, when followed within the abdomen, appears to be actually the spleen. And now on the right hand side, you can see the pulmonary window, where we can see this fully delineated patchy areas of pulmonary ground glass opacity to consolidation, distributed mostly ventral, which are compatible with the suspicion we already had about an aspiration pneumonia. So these are quite dramatic changes. So I have actually done 3 screenshots with the main changes to really show them. So we have a sagittal reconstruction from left to right. We have a transverse, and we have a dorsal reconstruction, and they're all soft tissue post-contrast. So the sagittal reconstruction reminds us actually of the radiographs we had. We can see the gas within the esophagus, and then we can see this organ, which has a double wall, and it's the stomach. And I've put asterisks within the wall of the stomach to show you the thickness of this gastric wall. When we measure it here in the center, we can see it's 1.3 centimeters, so that shouldn't be more than 5 millimeters normally. And what is actually concerning is that contrast uptake of the gastric wall is nice and regular here ventrally, but here when you go to the center of this of the slide here, you can see that at some point it interrupts. Here where I have shown you with the asterisk. So there is a equivocal lack of contrast uptake of the wall of the stomach. Also we can see that the spleen is entrapped within the invagination, and at the level of the spleen we have this well-delineated hypo-enhancing straight lesions that are most likely reflecting splenic infarcts. So summarizing the CT findings, we have definitely gastroesophageal intussusception with entrapment of the spleen, of some mesenteric fat and mesenteric vessels. We have also a severe thickening of the gastric wall with a questionable focal loss of gastric wall contrast uptake. And then we have severe compression of the splenic vein and artery with multifocal splenic hypoenhancing areas, which are probably infarcts. And we do have also an aspiration, or less likely a bacterial pneumonia. So in this case, CT confirmed the suspicion that we had with X-rays and revealed some worrying existing complications. Could we have achieved it with another modality? In this case, I feel that I should say probably CT was the best because yes, we could have done more radiographs, orthogonal views. We could have included the abdomen to check if there was a stomach visible in the abdomen, and the absence of a gastric silhouette in the abdomen would have confirmed the condition. But the patient would have been moved to the X-ray table, probably conscious, repositioned several times. And with that type of critical patient, that's not a thing that is always recommended. And also, it would have taken quite a bit of time. We could have done an esophagram because we would have seen that the esophagus was obstructed by what we know now is the stomach, but this is not recommended in a patient with megaesophagus, especially if we suspect that we are going in surgery afterwards, because at waking up from anesthesia, it would have probably inhaled some of the contrast that would have stayed in the esophagus because of the lack of motility. And with ultrasound, we could have gained some information looking at the abdomen and noticing that we didn't really see all of the spleen. But because in ultrasound, we cannot see actually the level of the diaphragm, because the diaphragm is just a leaflet, we don't actually see it. We would have seen maybe part of the stomach pointing towards the chest, and we wouldn't have known how much of the stomach actually was invaginated. And we wouldn't have been able to assess the vascularity of the gastric wall, which is an important information we have with CT. So how did it impact the patient? In this case, CT was the best option. The patient could go immediately to surgery, and we understood coexisting factors such as the gastric wall vascular supply, the splenic entrapment, the splenic infarcts, and the aspiration pneumonia, which unfortunately in this case make the prognosis more guarded. And this is an important information to be given to the owner before surgery, just to adjust the expectation in this unfortunate patient. So in this case, the key points of this case are that CT is an exceptional modality because it gives us really a lot of information in a very short amount of time, because it really doesn't take a lot of time to do a CT chest and abdomen. It is really a matter of minutes. And it is particularly useful when the patient is critical and the other modalities do not provide the same amount of information in such a short time. In this case, we injected the contrast because the patient was actually stable, but it could have been avoided. The diagnosis would have been achieved anyway. The only thing that wouldn't have been achieved is the information that the gastric wall could be necrotic. However, with that level of thickening, there would have been the doubt anyway. CT in these cases, when the patient is critical and cannot be fully anesthetized, can be done under sedation without any problem, and that reduces even more the risk of the modality. So you have a few literature sources here that you can have a look later for this condition that is actually quite rare, and we often forget about it, and it's quite important to recognize it in a critical situation. And finally, we get to the last case of the webinar, which is a French bulldog, 5 years old, with a history of an ongoing discharge inside the mouth. So the veterinarians described that there is this sinus within the inside area of the gum of the cheek, and when they try to catheterize it and to flush, they can see something swelling at the level of the right side of the cheek. So quite an unusual story. I do apologize, I don't have the dog's radiographs in this case. I have created radiographs from the CT, but I want to be absolutely clear, these are not radiographs, these are created from the CT. But I have done it just to show you how potentially a radiograph of this dog would have looked like. And as you can see, they are completely inconclusive for the condition. We don't really see much, and we cannot appreciate any soft tissue swelling because there isn't one, and there is no bone changes. So in this case, the radiographs would have been inconclusive. I have generated a 3D reconstruction of the face of the patient as if it was looking at us. And yeah, looking really carefully, we can see a very, very mild swelling of the right side of the cheek ventrally. So this is what probably the veterinarian could see physically examining the dog. So here I have on the right-hand side a right parasagittal reconstruction, soft tissue post-contrast. And on the left-hand side, I have transverse post-contrast, soft tissue again. So this structure indicated by the yellow arrows is the parotid salivary gland, and it is located just ventral to the external acoustic meatus. And here we can see again the parotid gland and this ventral hypotonic structure just ventral to the parotid gland, which we should focus on when we start the video. So we can see this tubular structure that is moving rostrally and ventrally. And if we stop and we put a region of interest, we can see that the attenuation is 8 ounce-filled unit. So this is indicative of fluid. So it's a fluid-filled tubular structure that originates within the parotid salivary gland. And let's see where it goes. So we are proceeding towards the nose of the dog. It goes ventrally, and then it ends up within the mucosa of the oral cavity, just at the level of one of the premolars. So we have an idea of what this could be. But I have a couple of reconstructions to show you where we can see that this is the level of the element under the height, the 4th premolar, and at the level of the distal, which is the rostral in this case, termination of the tubular structure, there are many hypoattenuating paths with a peripheral contrast uptake, and there is the generalized swelling of the side of the cheek at that level. This is a parasagittal reconstruction, and we can see that at the level of the most rostral aspect of the distended parotid duct, there is a distinct stenosis. We can see it's really suddenly changing the size of the lumen. And that immediately distal to the area where we see this swelling and irregular hypoattenuating paths. So summarizing the CT findings, this is an enormously distended parotid salivary duct. Usually we don't see the duct itself at all, so it's really distended. So it constitutes what we call a parotid duct ectasia. The duct is completely distended and it just narrows at the level of its termination. And we'd have a couple of incidental findings, periodontal disease and a bit of external otitis. So CT in this case was instrumental because it identified the cause of the clinical signs and the organ of origin. And it can allows us to formulate some hypotheses. For example, in this case, because there is a focal area of stenosis, we can imagine that this could have been something congenital and there has been a progressive swelling of the duct, or that it could have been a previous trauma, and this has caused the stenosis of the duct and then a distension. But we can exclude that there is a small hypertomating plug within the duct or a tiny foreign body. We have excluded other causes of facial swelling, importantly, so abscesses, tumors. Could have we done it differently? So in this case, we could have done a scalography. It could have been technically difficult because, as I showed you, within the oral cavity, the parotid duct papilla was quite irregular, and it seemed to be formed by several paths. So catheterizing the correct one would have probably been a bit tricky. With ultrasound, we would have been able to realize that this is a fluid-filled tubular structure and it starts within the parotid salivary gland. So most likely we would have reached the diagnosis, and we would have also been able to rule out a small plug within the distal aspect of the duct, not within the papilla. I don't think the papilla would have been visible, but probably the distal aspect of the duct. However, with ultrasound, we wouldn't have been able to have a 3D idea of how this structure was and where it was. So it would have been less informative. And with MRI, certainly we would have diagnosed the condition, but it would have been a bit more tricky because MRI is less used for this type of problems. So how did it impact the patient? The patient had a diagnosis, and this diagnosis was achieved non-invasively. So we didn't have to do a scielogram with long anesthesia. The next step can be discussed with the owner, and the exam, as I said, was completely non-invasive. So summarizing, CT is excellent for the osseous and soft tissue structures of the head because it depicts the regional anatomy with extreme detail because of the ability to have 3D reconstruction. And the thorough anatomic knowledge of the tomographic anatomy is very important for this type of conditions. And CT is really unparalleled modality for bone and soft tissues of the head. I think I do particularly enjoy CT of the head, other than pathologies that involve the brain and the cranial nerves, where CT is inherently less sensitive than MRI. So this condition, the parotid duct ectasia, has actually been described recently in 14 cases, and the breed, the French Bulldog, is predisposed apparently, but we don't really know the etiology because in 13 out of 14 cases, the cause wasn't found, and in one case there was a foreign body. So summarizing, because now we are at the end of the webinar, we have seen that CT is fantastic because it can give you a really fast diagnosis in situations that are critical and you really need to move on with your patient. Allows an excellent depiction of the anatomy in body regions that ultrasound and radiography cannot image. For example, I'm thinking about the axillary cavity, I'm thinking about the pelvis, caudal to the pubic bone, but also the retrobulbar space. In CT, I can measure the Hounsfield units, and this tells me what type of tissue or content I am looking at, and also its vascular supply, which, as we saw, was a very important aspect of the gastric wall in the dog with the gastroesophageal intussusception. And also, CT allows an assessment of all the abdominal structures in all size patients, so very small, from the rabbit really to the Great Dane. And in ultrasound, we can sometimes be limited to in the visualization of the dorsal structures in large dogs. But CT requires, of course, critical analysis of impact to understand what is relevant from what is not, and also expert interpretation. So thank you very much. This was my last slide. Thank you so much for listening. And then I am really happy to take any question.
Thank you so much, Olga. That was fascinating and some really interesting cases. Yeah, a spleen inside a dog's esophagus. I've not seen that one before. That's spectacular. Poor patient though, goodness me. I mean, in terms of you just alluded there with large dogs, that abdominal ultrasound can be tricky. Are there any other instances where you would prefer abdominal CT to abdominal ultrasound?
Yeah, so there have been cases where I was really surprised because abdominal ultrasound were remarkable. And then on CT, we found a relatively small mass in the very cranial portion of the liver, the one that is in contact with the diaphragmatic surface. That is a very difficult area for ultrasound, especially if you have a large patient or even a medium-sized dog with a very deep chest. We have to really be careful and to acknowledge the fact that ultrasound doesn't show the whole liver in those patients. Very deep chest or very large dog or obese dog, for example, an obese Labrador, we wouldn't be able to explore the whole liver. And that's very important because we want really early detection if we have a mass at that level. And then, as I said previously, anything caudal to the pubic bone, because there is the shadowing of the pubic bone, and we cannot see the wall of the rectum and a part of the urethra.
Okay, great. And yeah, please, if there are any additional questions from the audience, please pop them in. But whilst we're on the topic of the abdominal CTs, again, do you always recommend using contrast because of the additional information?
Well, for abdomen, we really recommend, if you can, please inject a contrast because the amount of information you have with the contrast is superior. For example, if you have an area of abnormality within a parenchymatous organ, such as the liver or the spleen, and we have an abnormality that is not deforming the profile of the organ, it can still be clinically relevant, but without the contrast uptake, we are going to probably miss it. And that's a problem. Some metastases, for example, can be this way. I would say, however, that if you have a patient that is critical and cannot tolerate the contrast, or you have a patient that has a very bad renal disease and contrast is really contraindicated, CT can still have value. For example, in the case I showed of the gastrointestinal intussusception, the diagnosis would have been achieved anyway. And the same would have been if you had a patient where you suspect a splenic torsion. CT without contrast would be diagnostic anyway. I think at some point there is a decision that you have to take, which is, am I going to be better doing an ultrasound or doing a CT without contrast? And the answer will depend case by case. But of course, if you have this question, you can reach out to us and we can advise you on what would be the best modality for that case.
Yeah, that's a really important point, actually, is, our radiologists aren't just here to interpret images. They're great at actually supporting pre-imaging with modality selection, which can actually be super powerful to make sure you get the correct imaging for your patients, or in the correct order. And I know that we do share contrast guidelines with our clients as well, to help support them with that decision making. So yeah, thank you for discussing that. The other thing you mentioned with CT of the head, you showed just the absolute power of it there in that sort of very detailed exploration of the parotid gland and duct. And I know you mentioned that obviously for brain imaging, the MRI can be superior, but are there any diseases of the head for which CT is not indicated?
I would say probably not indicated, no. But as you said, Liz, yes, if you have a problem within the brain parenchymal or cranial nerves, it depends. So your results are a bit less reliable. For example, if you have a really massive necrotic meningoencephalitis, it is very possible that the lesions, because there is a necrotic center, will have a hypoattenuating center and a contrast uptake around. So with CT, we can pick them up, and we have seen a few cases of that. However, in many cases, meningoencephalitis CTs are normal. And the same is true for minor cerebrovascular accidents where there is not a mass effect. And in those cases, MRI is obviously more sensitive, gives you more confidence with your diagnosis. But said that, most of the times when you suspect a meningoencephalitis and you're a neurologist or person with neurologist interest, you will end up doing a CSF anyway. So we do have some clients that do not have a CT available, or they are in geographic reasons where there is not an MRI. And in that cases, CT still has a value because can rule out other conditions. And with that and the ability to do a CSF, if appropriate and safe, they can still reach a diagnosis.
Okay, that's really great. Thank you. I can't see any more questions that have popped in, so it just remains for me to say a huge thank you to Olga for sharing these, and just to remind people that you will be receiving the recording via email. We will also put it out on social media. Please do share it with others if you found it helpful. We hope you enjoyed it, and thank you very much for joining us.
Thank you very much.